Dr. Girish Tyagi, sir, please come, sir. He is the, we all know, he is the Secretary of Delhi Medical Council and past President of Delhi Medical Association. Then Rohan Krishnan, I think he's Rohan Krishnan. Where is Rohan? Rohan Krishnan, he is the President of the Junior Residents of Doctors Association. Then Dr. Paras Gangwal, Dr. Gangwal he is a senior physician practicing in Salim Argan, and presently he is the President of Delhi Physician Forum. And Dr. Rajiv Sood will be joining on online. Then other panelists are Dr. Praveen Bhatia. Dr. Praveen Bhatia is a senior consultant and is director of Bhatia Medical Institute in Jahangirpuri. And the concluding remarks will be Dr. Gaurav Agrawal. He is the HOD Forensic Medicine at NCRIMS, Meerut. Dr. Gaurav Agrawal, please. I welcome Dr. Rajiv Sidhi has come in line, so he will be participating in this. Dr. Chavda, please.
First of all, I would like to thank you, North Delhi Physician Forum, given the opportunity. Dear friends, as you know, this topic is very, very important. Incidents happens, but what happens after that? शोर हल्ला गुल्ला सब कुछ हो जाता है, थोड़े दिन बाद वही की वही बातें, वही दाल, वही सब कुछ वही रहता है. लेकिन कुछ हम उस पर करना चाहेंगे कि कुछ हम क्या कर सकते हैं. आज हम दो टॉपिक लेंगे. First of all, this presentation is exclusively for the education and the motivation purpose. There is no conflict to interest of any intention to hurt anyone in person, fraternity, government, media, association, or the organization. In fact, it is an observation and evidence-based presentation. So, dear friends, doctors are soft target for everyone. Public, government, media, everyone. Doctors are soft target. हर बंदा आता है जैसे मंदिर का घटना होता है ना, जो आता है मार के चला जाता है. Am I right? I will ask the panelists. Am I right? Doctors are soft target. Everybody agree with me.
डॉक्टर छावड़ा, इससे पहले जो अपना डिस्क्लेमर लिया ना, आप एनडीपीएफ एक एसोसिएशन है जो कि इश्यूज लगी, अगर पॉलिटिकल को आपको पॉलिटिशियन को हर्ट करना हो, पुलिस को हर्ट करना हो, आपका फोरम है इसलिए कि उनको हर्ट करो उनको यार. ये डिस्क्लेमर की कोई जरूरत नहीं है.
मतलब go ahead. You can go ahead. Thank you, Dr. Girish Tyagi. The question to the Girish Tyagi, is it true? Yeah. So इसने endorse कर दिया. Thank you very much, Dr. Girish. So in present era, what happens in this? Doctors का क्या हाल हो रहा है? Corona cases, you have seen all the load on the doctors, politicians, and the IS are away, going away. They are not responsible. So as of today, burden of the doctors, just like that, they are doing the card with the head on the card. So as of today, doctor safety versus the patient safety, we give types of the safety to the patient. But what we get instead versus this type of the safety. So not fair. So dear friends, question to the panelists, what is your opinion about the effect? एक एक बताइए. Dr. Girish, पहले आप बताइए. सारा लोड डॉक्टर पे होता है.
सर पहली चीज तो है कि जो आपका because we are here all the clinician, first point is that treat every patient as a potential litigant. अगर आप हर पेशेंट को एक लिटिगेंट की तरह ट्रीट करेंगे तभी आप सेफ्टी रह पाएगी, अगर आपकी सेफ्टी है ही नहीं.
ओके.
उसके बाद जो भी स्टेक होल्डर्स हैं, पुलिस, मीडिया, पॉलिटिशियन, गवर्नमेंट, मेडिकल काउंसिल, कोर्ट्स आर ऑलवेज अगेंस्ट द
डॉक्टर
प्रैक्टिशनर, क्योंकि ये सॉफ्ट टारगेट है. आराम से हम बजा हो जाते हैं, आराम से कोई भी आके पुलिस का, यानी कि डीसी भी आएगा, पुलिस का अगर वहाँ पे कांस्टेबल भी आएगा ना आपके उस पे, तो आप उसको ट्रीटमेंट भी फ्री करोगे, दवाई भी दोगे उसको, आगे उसको उसके लिए ना उसके रिश्तेदारों के, उसके दूर दूर के रिश्तेदारों के लिए करोगे. तो ये सारा चैरिटी का काम बंद करते हुए टोटली प्रोफेशनल तरीके से काम करें, एथिक्स तरीके से काम करें. दिस इज माय वर्ड.
Rightly said. I will ask the Dr. Rajiv Sood. He is on the line. Dr. Rajiv Sood, what is your opinion?
See, as Dr. Girish Tyagi has rightly covered it, that what are the duties of various stakeholders and how they are involved, and how the doctor or practitioner is made the soft target. One thing is clear, that in Archana Gupta case, when this happened, if she has not committed suicide, nobody would have noticed so much. And even then, the 302, that is the attempt to murder, or the murder charges were leveled against her. And the role of politicians were having they took the dead body and they raised the dharna outside the nursing home. And it has been alleged that more than 1 CR was the extortion money which was demanded to stop all these agitations. So if these all allegations are true, and we can believe that they are likely to be true, otherwise nobody will take away our own life. And after that, if this was not reported, it was 302 section, attempt to murder. She was going to be arrested. And also after this, it was proven that many of the allegations which were leveled against the local administration, police, and also the role of other factors which were there, how the doctors are tortured, and that all was taken to the court ultimately.
Right.
And I'm happy to share with you that in Archana Gupta case, we have moved the Supreme Court, the Delhi Doctor Forum, and also the Dwarka Group. And now this case has been admitted. But the question is that why we have reached to that stage and what will happen. Now what we are facing, to fight for PIL also, directly, indirectly, lot of money is required for litigation. If you want to hire a senior advocate, even then that costs. So we are in problem. We are soft targets. We need money for litigation, and litigation is taking time. Even first hearing is not done. So this is the situation in Archana Gupta case.
Thank
The first
Dr.
which you
Rajiv,
have
Dr.
taken.
Archana Gupta nahi hai, Archana Sharma hai. That is Sharma, Archana Sharma.
Archana,
Thank you very
sorry,
much for your
Archana
comment.
Sharma.
Because case is going on in the Supreme Court. Thank you very much, Dr. Rajiv. Now, impact of the assault or the anything on the doctors lead to the physician burnout. You see, personal as well as the professional. Personal, broken relationship among the doctors, and they are abused to the alcohol or the other drug abuser. Doctors will go into the depression, ultimately suicide, as you have seen in the Archana Sharma case. This is the scenario of the doctor's assault. And professionally, decrease in the quality care and increase the medical error, the chances of the medical error, and decrease patient satisfaction. We cannot satisfy the patient, and ultimately decrease productivity and the professional efforts. So I will ask Dr. Bhatia, what is your opinion about the physician burnout?
Regarding the physical violence, basically, this can vary from even from intimidation to physical violence, may lead up to lynching, sorry to say. But in this particular case, what would have been done is, what association has to be very strong, number one. And we should never criticize any doctor, any of us colleague in front of the patient. That is my advice.
Thank you. Thank you. I will ask the Dr. Paras Gangwal, what is your opinion? Young generation are not opting for the even medical stream. This is a big problem. What is your opinion?
So my task about all these is that there used to be an era when we used to practice like patient ki jeeb bachao or jaan bachao. In last 1 to 2 years, the things are happening in such a manner, so drastically, so noisy they have become. The whole thing has probably changed to first I have started thinking ki apni jaan kaise bachao. So it has to be fully documented, and by seeing all these things, that's why our generation, the younger generation is not opting to become doctor, is probably one of the reasons that we would be facing more legal hurdles now onwards.
Thank you. Then in spite of facing Doctors are morally duty bound and especially justified their role as the COVID era. You have seen the COVID era. What happens? What a great picture which shows how a doctor is trying to save the life by not caring about his life. Salute to painter who has brought this slide. Dr. Pasu was saying, in spite of we think we want to save the patient in any cost. We don't even care about our own life. So even you see the more than 250 doctors COVID martyr. उनको compensation मिला नहीं मिला, that is different issue. But even they are not acknowledged by the government. So a question to the panelists: what are Dr. Gaurav, so Dr. Rohan? So because young generation is more prone to the assault. What is your opinion?
Yes, sir, obviously, because what we see is that when it comes to emergency duties, most of these cases which is happening of assault and violence, fear death or they have suffered death. तो डेथ जब भी होता है ये यूजुअली इमरजेंसी ड्यूटीज पर जो पेशेंट रहते हैं उस पे होता है, और जो यंग डॉक्टर्स रहते हैं चाहे वो हमारे पोस्ट ग्रेजुएट रेजिडेंट्स हों या सीनियर रेजिडेंट्स हों, they are always on duty when emergency work is going on. So obviously they face the blunt of violence against doctors as the first line. And secondly, many of times what we see is that there is a non-cooperation from various institutes, because when such incidents happen, some of the political mafias gets involved and they pressurize the respective directors, the medical superintendents of the institutes, that not to file an institutional FIR and various other problems. I'm not just talking about Delhi, but if you talk about pan-India, this has become a major problem that the MLAs and MPs tries to manhandle and also make fear to the medical directors and superintendents. So that is a major concern, especially out of Delhi. In Delhi, touchwood, we have seen that the directors and the senior professors are with us, but in many of the other states, be it UP, be it Rajasthan, there is a lot of difference in the treatment by the directors to such goons and mafias. So this becomes a problem.
Thank you, Dr. Rohan. You are the national chairman.
एक मिनट, इसी पे कमेंट करना। डॉक्टर रोहन, जो आप कह रहे हो ना कि दिल्ली में ऐसा नहीं, दिल्ली में भी यही हाल है यार। जो मेडिकल सुपरिटेंडेंट, मेडिकल डायरेक्टर, इससे पहले जो एक रेजिडेंट पिटा वहां पर, उसके बाद इंस्टीट्यूशनल एफआईआर के नाम पे एम्बेसी ने कहा कि यू लॉज एन एफआईआर ऑन योर बिहाफ। ये इंस्टीट्यूशनल एफआईआर की एक फोरम था इन व्हिच आई वाज शेयरिंग विद द चीफ सेक्रेटरी बाय from the podium I said that because medical superintendent, medical director, head of the institute are not going for that FIR, that on that platform, chief secretary direct health secretary to, then the order was passed that institutional FIR will be lodged. Now the medical, even then हमारे डॉक्टर वहां पिटाई क्यों करते हैं? अल्टीमेटली the head जो वहां पर सीनियर डॉक्टर्स हैं, they are not willing to come to that spot. अगर सीनियर डॉक्टर वहां पर स्पोर्ट्स पे आएंगे तो बिकॉज ऑफ मैच्योरिटी दे कैन हैंडल द सिचुएशन वेल, बट जूनियर डॉक्टर जो अभी 20-22 साल का आया है, उसके बाद ये अपना ही इज आल्सो वेरी एग्रेसिव, तो वहां पर जो सिचुएशन कंट्रोल में रहती। सो नोट दैट कि दिल्ली में ऐसा हाल नहीं है, दिल्ली में वही हाल है जो बाहर हाल है।
हाँ डॉक्टर मनीष, व्हाट इज योर ओपिनियन?
बिल्कुल सर, मैं भी मानता हूँ, ये बस यही बात थी कि घर की बुराई नहीं कर रहा था पब्लिक में। तो दिल्ली में भी यही
here to discuss, not burai, we are here to discuss.
So ये
Openly
बात
discuss it.
I fully agree, and I know the incident of the hospital which sir is talking, and it is a fact that we literally have to fight many of the times in Delhi that the MS says that you file an FIR on your own, you file individual FIR, and the modus operandi of the police, the constitution, everything changes when senior professors are not standing with you. Okay. Then it becomes आप भी तो डॉक्टर साहब गुस्से में थे, आपने भी तो बदतमीजी करी।
Yes. We will come to this. Dr. Manish, what is your opinion?
सर जितने वायलेंस के केसेस होते हैं हम लोग पहुंचते हैं, मतलब जब रेजिडेंट का कॉल आता है तो पहुंचते हैं, लेकिन प्रॉब्लम आती है कि कोऑपरेशन की कमी होती है खुद में। मतलब अगर सोचता है कि रेजिडेंट पिट रहा, एमएस सपोर्ट नहीं करते, मैक्सिमम जो यही प्रॉब्लम है, बोलेंगे आपने कुछ किया होगा, पहला ब्लेम लगता है कि आप ही ने किया होगा। मतलब ओवर स्ट्रेस, ओवर वर्क सारे हैं, मार खाते हैं, फिर भी बोलते हैं कि आपने किया। उस टाइम में हमें जरूरत होती है कि अगर आप आइए सपोर्ट कीजिए हमारा, लेकिन वो नहीं मिलता। दूसरी बात होती है कि कई बार ईगो का प्रॉब्लम आती है, खुद के पैटर्निटी अपने खुद के प्रोफेशन में है, ईगो बहुत बड़ा इशू है। कि बोलते हैं अगर किसी का रिस्पेक्ट ना करे तो बोले अच्छा चलो ठीक है पिट रहा पिटने दो।
ओके
सर आपको याद होगा एक
Thank you.
इंसिडेंट हुआ था 2 साल पहले, एक आई स्पेशलिस्ट को स्टेज पर एक पॉपुलर सिंगर ने थप्पड़ मारा था। उसको डीएमए ने बोला कि ठीक है वी आर विद यू टिल एंड बट यू गिव इट इन राइटिंग।
वो उसमें किलोमीटर मार्च में लूंगा सर
हाँ,
आपसे आपसे लूंगा
वो
मैं-
भाग गया, कहते मैं लिख के नहीं दे सकता। तो उसको जब तक वो खुद ही तैयार नहीं होगा तो डीएमए क्या कर लेगी,
Yes.
एसोसिएशन क्या कर लेगी? you know?
बिल्कुल राइटली सेड। जब हम पीछे हट जाते हैं कि मैं तो पिट गया, अरे आप अब पिट गए तो पिट गए, लेकिन दूसरे ना पिटे, आपको उसके लिए लड़ना है, उसके लिए कोई नहीं लड़ता। राइटली सेड यू आर। थैंक यू वेरी मच। नाउ आई विल कम टू द नेक्स्ट। अच्छा डॉक्टर सारा यू वांट टू से क्विक बताओ क्विक।
वन में इंडिया का पहला कार्निवल प्रोटेक्शन एक्ट मेरे पूरे इंडिया का केस था 1988। 3 साल के बाद पर्सन मेरे घर आया, उसने कहा मेरी जान पहचान है, मैं केस करूं। उसने कहा यह मुझे 50,000 रुपये दे दो। उस समय मेरी प्रैक्टिस 10,000 थी। ऐसा जॉब मैंने खत्म की थी 1986 में। 5 साल के बाद जब मैं 15,000 कमाता हूँ, उसने मेरे ऊपर 50 लाख का केस किया और कह गया तेरे भाई तेरे साथ है, 1 करोड़ का घर है, घर बेच के 50 लाख मुझे दे रहे। केस को मैं लड़ा, 16 साल लगे, 1996 में मैं जीता। लेकिन आज वही डिस्कशन चल रही है जो उस समय चल रही थी। इन चीजों का कोई सोल्यूशन नहीं ना निकलेगा, बिकॉज पॉलिटिकली आप उन लोगों को सपोर्ट करते हैं जो आपको सपोर्ट नहीं करते।
थैंक यू डॉक्टर सारा। ये मैं मान नहीं सकता कि
I
डॉक्टर
strongly
सारा
disagree.
मिलेगा।
We'll talk later.
Just डॉक्टर
With due respect.
टाइम बड़ा कम है।
डॉक्टर छाबरा,
ये बिल्कुल सही बात है कि कुछ नहीं निकलेगा। आपने सोचा था 370 कभी हटेगी नहीं, हट गई ना। अपने को ट्राई करनी पड़ेगी, चाहे हटे चाहे ना हटे, हम ट्राई कर रहे हैं सर। थैंक यू।
मे आई कमेंट डॉक्टर छाबरा?
व्हाट इज द वी हैव लर्न फॉर द
डॉक्टर छाबरा,
as the our chairman of the PAIMA, Dr. Rohan, what is your opinion? What you
Sir,
learn?
Bond policy is something that we all have to think upon, be it a senior person, be it a junior person, because सारे senior doctors के बच्चे भी doctors ही बनते हैं 90% of the times. तो bond policy अब एक ऐसा बंधुआ मजदूरी हो गया है कि आप हमारे यहाँ से MBBS करिए, 6 साल अब आपको इन्हीं गवर्नमेंट सेक्टर में नौकरी आपको करनी है। तो पहला नुकसान आपको क्या होता है कि आपकी पीजी का जो एस्पिरेशन है वो डिले हो जाता है। ऑलरेडी आज एक बंदा जब तक MBBS, MD, SRशिप करता है तो उसकी उम्र कम से कम 32 साल हो जाती है। इसमें अगर आप 6 साल का और बैरियर लगा देते हैं तो इट बिकम्स 38 ईयर्स, जो कि बहुत ही ज्यादा भयानक है, बच्चों को बहुत दिक्कत है। और इसके साथ जो पॉलिसी तोड़ने की बात होती है, तो अभी हरियाणा का जो मुद्दा था उसमें 25 लाख बॉन्ड पॉलिसी को तोड़ने की, लेबर मिनिस्ट्री ने ESI का भी पॉलिसी लगाया 25 लाख। सो इट इज लाइक कि आपको करना ही पड़ेगा। तो बॉन्ड पॉलिसी, व्हेन देयर आर अ लॉट ऑफ मेडिकल कॉलेजेस, व्हेन गवर्नमेंट इज ओपनिंग सो मेनी मेडिकल कॉलेजेस, व्हेन ऑल ऑफ अस थिंक कि भैया हमें डॉक्टरों की कमी नहीं होने वाली है अभी नियर फ्यूचर में, तो बॉन्ड पॉलिसी का तो कोई मतलब नहीं होता है। क्योंकि अगर मेरा रैंक 50 है और मैं बॉन्ड पॉलिसी के वजह से कोई गवर्नमेंट कॉलेज नहीं उठा पा रहा हूँ, और रैंक 75 अगर बॉन्ड पॉलिसी को फॉरगो करना चाह रहा है, उसके पास पैसे हैं कि मैं 25 लाख दे सकता हूँ, तो वो मेरे साथ तो बहुत बड़ा इनजस्टिस है। सेकेंडली, डॉक्टर्स के बच्चे तो फिर भी चलो हम लोग कूद जाते हैं, लेकिन बहुत सारे ऐसे बच्चे होते हैं जो किसी फार्मर के बच्चे हैं, जिनके पास किताब खरीदने के लिए 4,000 रुपए नहीं होता है, वो 7.5 लाख रुपया, 25 लाख रुपया बॉन्ड कहाँ से देगा? और जब इंजीनियरिंग में नहीं है, IIT में नहीं है, IIM में नहीं है, तो वाई सो मेनी एक्सपेरिमेंटेशन विद द मेडिकल फील्ड, स्पेशली इन केस ऑफ बॉन्ड पॉलिसी एंड कॉन्ट्रैक्चुअल एसआरशिप। मैं इस पे भी बोलना चाहूंगा कि कॉन्ट्रैक्चुअल एसआरशिप का जो मुद्दा है बहुत सीरियस है। हर 39 डेज पे आप अपने HOD के पास जाइए, आपको बिल्कुल विक्टिमाइज किया जाता है, ब्रूटलाइज किया जाता है, आपका अपना कोई से नहीं होता है डिपार्टमेंट में। आपको जिस तरह की ड्यूटी करने बोलते हैं आपको करना पड़ता है, क्योंकि फिर आपको हर 39 डे पे या 89 डे पर उनका सिग्नेचर्स लेना है। अगर आप नहीं ले रहे हैं तो आपकी एसआरशिप वहीं पे खत्म हो जाएगी।
थैंक यू।
तो ये बहुत ही वी हैव टू थिंक
राइटली सेड किया, ये पॉलिसी नहीं होनी चाहिए। मैं पहले मैं आपसे बात करना चाहता हूँ कि हमने आपको स्पेशली इसलिए बुलाया यंग डॉक्टर्स को, क्योंकि आपको बुलाया नहीं जाता, आपकी प्रॉब्लम सुनी नहीं जाती, इसलिए बुलाया गया है। हमारे पास अथॉरिटी बैठी है, डॉक्टर गिरीश त्यागी है। पहले बात हुई है, डॉक्टर गिरीश त्यागी इस फेवर में है कि राइटली आप दिल खोल के बोलो जो बोलना चाहते हो। तो मैंने इसको कहा इसके साथ नहीं बोलना चाहिए, इन्होंने मेरे को कहा नहीं डॉक्टर छाबड़ा, हमें वही बोलना चाहिए जो हमारे दिमाग में है।
इसलिए क्या
Thank you,
कि आपको
Dr.
डिस्क्लेमर को वहां से हटा दो कि
हाँ,
मैं
ये
किसी
लेवल
की
का
feeling को
डालो।
हर्ट नहीं करूंगा पहले।
इसलिए मैं इनको थोड़ा एंडोर्स करता हूँ। थैंक यू वेरी मच डॉक्टर गिरीश त्यागी।
आज का
So I will
topic
come, yes,
we are waiting for the topic.
आपने
main
देखा
topic.
होगा कि देखो इस तरह के आप देखिए बंदा एक पेशेंट मर गया तो उसको क्या होता है, हाउ टू इंडिया ट्रीट द पेशेंट, पेशेंट इज डेड, लेट अस बीट द डॉक्टर, दिस इज द, so what is the treatment? Now time is very short. ट्रीटमेंट क्या है? ट्रीटमेंट क्या है? सोल्यूशन, हम जितनी आपने नो फ्रूटफुल और द मीनिंगफुल सोल्यूशन टिल डेट वाई, अभी तक कोई सोल्यूशन नहीं है। डॉक्टर ने कहा, सर ने कहा कि इसका कोई इलाज नहीं है, इलाज है, हम करेंगे। तो lack of the coordination among the IMA, its branches, other medical association like the API, CSI, RSDI, सब कहते हैं हम अकेडमिक है। अरे अकेडमिक हो कि क्या करोगे? ये वाला भी जरूरी है बच्चों के लिए, हमारी इनिंग तो खत्म होने वाली है, लेकिन यंग जनरेशन के हमें कुछ करना है। So other reason for the failure, transformation of the doctor of the politician. एक डॉक्टर कोई पॉलिटिशियन बन गया तो पॉलिटिशियन ही बन गया, वो डॉक्टर खत्म हो जाता है। अदर इलेक्टेड ऑफिस बीरर एंड द एग्जीक्यूटिव मेंबर डोंट जस्टिफाई देयर रोल, वो लेटर पे नाम आ गए उसका सब प्लीज पूछूंगा, टाइम बड़ा कम है सर, मेरे को बड़ा टाइम कम दिया उन्होंने। एज द प्रेसिडेंट, सेक्रेटरी, ट्रेजरर, अदर ऑफिस बीरर, दे ओनली फॉर द दे आर नॉट अलाउड टू द ड्यूटी, even president elect don't come to the office. So we have to see this, what is our aim or the motive of the presentation. As per our past record, everything gets cool after few days, protest, halla gulla, debate, argument against the incident with no proper solution, and this is the time. उस वक्त अर्चना के समय में सोचा था कुछ होगा, लेकिन वो भी धीरे 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 करके खत्म होता जा रहा है। So we must motivate or reactivate till the justice to the Archana Sharma. हमें पब्लिक को साथ लेना पड़ेगा, कोई कैंडल मार्च करने पड़ेंगे, इंडिया गेट पे खड़ा होना पड़ेगा, तब हम यंग जनरेशन को कर सकते हैं, अन्यथा नहीं कर सकते। प्रॉपर रेमेडी, कंबाइंड एफर्ट्स होनी चाहिए। IMA इज द बिग कंसर्न, हमारे जितने भी एकेडमिक है उनको साथ करना चाहिए। हम एकेडमिक करेंगे, हम साथ नहीं दे सकते, लेकिन उनको एम्पावर करना है हमने टू हुम वी आर आंसरेबल, हम बच्चों के लिए करना है। तो प्रपोज रेमेडी सब जितनी भी है IMA को करें, उनको बोलो कि हम अकेडमी का आपका साथ देंगे, हम आपके प्रोटेस्ट वगैरह में अकेडमी से क्या जाएंगे, लेकिन उनका साथ पूरा देना है। IMA को स्ट्रॉन्ग करेंगे, तो IMA स्ट्रॉन्ग करेंगे तब हम सोल्यूशन मिलेगा। उनको कह दो भी तब सोल्यूशन देंगे, हम आपका साथ देंगे, कब कुछ करोगे तो रेमेडी इन आवर हैंड। सिलेक्शन अच्छा पॉलिटिशियन होना चाहिए, 3D होनी चाहिए, डायनेमिक देयर पॉलिटिशियन होना चाहिए अपने, और डायनेमिक देयर दबंग होने चाहिए, और इस तरह के पोस्टर सब क्लिनिक पे लगाने चाहिए। पब्लिक कहती है मेरे को पता ही नहीं है, पब्लिक को बताओ, अगर आपने तोड़ दिया तो ये हो जाएगा, लोगों को पता नहीं, जैसे अर्चना केस में हुआ था, उनको पता ही नहीं उनका, अब 302 में अंदर कर दिया उनको, फटाफट और कर लिया। तो इस तरह के पोस्टर तो 31 अक्टूबर 2021 में किया था, डॉक्टर रणदीप ने किया था इसको पोस्टर लॉन्च, ये अपनी क्लिनिक पे होना चाहिए। और व्हाट वी डू, वी वांट द क्लैपिंग और द फ्लावर, द कैंडल लाइटिंग एंड द डॉक्टर विल कैंडल लाइट कर दो, वी डोंट वांट दिस थिंग। We want the central law of the violence to the doctor or the medical service, and we do appeal to the our prime minister to say in the मन की बात, मन की बात में कहे कि डॉक्टरों के अगेंस्ट बात नहीं, क्योंकि पॉपुलर प्रोग्राम है, और वर्किंग प्लेस पे जीरो टॉलरेंस चाहिए। टेक अ मैसेज, change the attitude to harm the harmony among us, and team work with all the things, and humble advice there will be no, आप सोचो कि मिस्टर इंडिया आएगा आपके लिए काम करेगा, नहीं, अपने आप ही करना पड़ेगा। तो ए मर्डर इज द इनोसेंट टिल प्रूव्ड गिल्टी, बट ए डॉक्टर इज गिल्टी टिल प्रूव्ड इनोसेंट, दिस इज द सिनेरियो। सो लेट अस टुगेदर टू रिवाइज दिस। So we don't want, dear friends, another Dr. Archana. This is my message. So we want justice for the late Archana Sharma. इसको रिएक्टिव करके इसको द्वारा किया जाए, कैंडल लाइट करके कुछ इसको किया जाए जब तक उसको डेट नहीं मिलता। Now I will say Dr. Gaurav for the concluding remarks. Thank you.
Thank you, Dr. Arvind Mohan.
थोड़ा सा आपसे कंक्लूड
आपको ट्रीटमेंट दिया सर, अच्छा
कोई-
बहुत बहुत।
डॉक्टर गुरु कंक्लूड करेंगे। उससे पहले सर, एक तो पहले मेडिकल एसोसिएशन, जब तक हम अपना एटीट्यूड नहीं बदलें, मेडिकल एसोसिएशन शुड बिहेव एज अ ट्रेड यूनियन। अगर कहीं पे गलत होता है, वी शुड, जो हमारा है कि हम स्ट्राइक नहीं करेंगे, और अगर कोई कॉल की 24 आवर कॉल आपने करी इस बंद के लिए, उसमें आपका पड़ोसी खोल रहा है, तो वी हैव टू बी वेरी यूनाइटेड और ट्रेड यूनियन की तरह अगर कोई नहीं खोल रहा, नहीं आपके साथ चल रहा, तो पकड़ के पीटो। मतलब यही आपको करना पड़ेगा आपको। अगर आपको ट्रेड यूनियन की तरह जहां पर कहीं पे गड़बड़ है, तो वी शुड बी यूनाइटेड, डोंट क्रिटिसाइज अवर ओन कलीग्स फर्स्ट ऑफ ऑल इन फ्रंट ऑफ पब्लिक। अगर कहीं पे हमारी गलती है तो हम आपस में प्लेटफॉर्म पे एक दूसरे को गाली दें, पकड़े, जो मर्जी करें,
Yes.
बट नॉट इन फ्रंट ऑफ पब्लिक।
डॉक्टर त्यागी त्यागी ने बहुत ही बढ़िया बात बताई है। वन भी आप अथॉरिटी हो सर, पावर हो। जैसे क्वेश्चन पूछा था डॉक्टर आर के गुप्ता ने, ये आप अथॉरिटी तक कैसे आपने इस चीजों को आगे पहुंचाना। हम यहाँ डिस्कस करते हैं, आप पावर में हो सर, आपने डीएमसी में समय
कोई
पहुंचाना है।
पावर में नहीं है हम ऐसे।
नहीं सर,
जब
आप डॉक्टर हमारे साथ हैं, लेकिन आप इन बिटवीन हो सर।
नहीं सर, जो पावर में सर, पहली चीज तो जो आपके, पहली चीज आपने कहा ना, डॉक्टर जो हमारे डॉक्टर पॉलिटिशियन बने सबसे थर्ड क्लास वही हैं। डॉक्टर हर्षवर्धन, अदर पॉलिटिशियन फ्रेंड जो हमारे बैठे हैं, डॉक्टर अर्चना शर्मा के केस में कितने पॉलिटिशियन जो हमारे डॉक्टर थे, उन्होंने वहां पे लोकसभा में रेज करा। नन ऑफ देम, नॉन पॉलिटिशियन वहां पे रेज कर रहे हैं, बट हमारे अवर ओन डॉक्टर कोलीग दे आर नॉट कंडेमनिंग दैट एक्ट।
डॉक्टर त्यागी,
इवन देखो आप ये
लेकिन मुझे ये बताओ, जब हर्षवर्धन इलेक्शन लड़ता है, डीएमए के लोग उसके ट्रक के आगे फ्लावर्स लेके पेटल करके क्यों कर रहे होते?
यस,
यू आर करेक्ट। व्हाई द डॉक्टर्स आर देयर लाइक
यस,
स्लेव्स? दे आर स्लेव्स टू
यही बंद। डॉक्टर गिरीश त्यागी यही तो कह रहे हैं।
We are soft targets, we are not united, and we are enough to finger each other. That's why the society is riding us. That is why any
डॉक्टर चावला वही तो गिरीश त्यागी कह रहे हैं, वही गिरीश त्यागी कह रहे हैं। डॉक्टर गौरव,
यही बात है
Dr. Tyagi is saying same thing. Dr. Girish Tyagi ने same बात कही।
There is one thing that we should act like trade union.
वही तो गिरीश कह रहे हैं।
In today's era, क्या होता है कि मैं पहले डीएमए में कोई पोस्ट ले लूं या आईएमए में पोस्ट ले लूं, और जिस दिन मुझे डीएमए आईएमए में पोस्ट मिल गया, मैं ये कोशिश करूं कि मुझे बीजेपी में कैसे पोस्ट मिल जाए, मुझे कांग्रेस में कैसे पोस्ट मिल जाए, मैं कैसे हाउस में चला जाऊं। तो ये मेंटालिटी जो डॉक्टर्स की हो गई है, खास करके जो लीडरशिप की हो गई है, चाहे वो इंडियन मेडिकल एसोसिएशन हो या कोई भी एसोसिएशन हो, ये बिल्कुल ही हमें मान के चलना होगा कि इफ अ डॉक्टर हु इज लीडिंग एन एसोसिएशन शुड नॉट थिंक ऑफ एनी पॉलिटिकल एक्टिविटी एटलीस्ट फ्रॉम 5 years till from the date he resigns from the office. ये चीज को हमें लेके चलना होगा। ये इंट्रीगेट नहीं है कि अब नेता बनना है तो हमें आईएमए के थ्रू।
So I'll before that, just a moment, please. No.
I have we had enough of doctor doing this and that. I want to raise a simple point. When Supreme Court has come out with a judgment, no doctor can be arrested. Why are we failing to educate the policemen?
Yes.
Why don't we follow Supreme Court judgment against
The
them?
fault is ours.
Is
I
it
tell you
पुलिस को
why.
वर्कशॉप करने पड़ेंगे।
हमारी गलती है।
Is
मैं
it
बताता
because
हूँ
their
क्यों।
governments are
वर्कशॉप करने पड़ेंगे पुलिस में।
they are not liable for legal action? Just clarify this point. Are they because being a government servant, are they liable not to be going for the contempt of Supreme Court?
Of course they are.
We should.
But
then-
हमारी गलती का है, मैं बताता हूँ। आप in answer to yours and respected gentleman over here, sir, senior person. So issue का है, how many of us did do you know कि जो डॉक्टर साहब ने पोस्टर दिखाया कि वो कानून एग्जिस्ट करता है? Any raise of hands? Can I see a raise of hands? How many of us know about it? कि there is a anti-violence act for doctors. I see only 3, 4, 5 hands. Okay, so about more than 50% of us do not know. Public को तो बाद में बताएंगे, पहले हमें नहीं पता है.
तो पोस्टर लगाने
So a
पड़ेंगे।
very big deficiency in our medical curriculum. जब हमने MBBS की थी, medical law नहीं थी उसमें. Now the MBBS curriculum. How many of us from medical colleges? Anybody here? Okay. So MBBS curriculum is not same as it used to be. Now since 2019, 4 years हो गए, एक नया MBBS curriculum आया है, and because of all this feedback, what we are talking about, the erstwhile MCI, now the NMC has changed the MBBS curriculum, और उसमें 180 hours, 180 घंटे नए आए हैं. What is this about? It is about medical law and medical ethics, mind you, and it starts from first day of MBBS till the last day of MBBS. और उसमें first month में MBBS में teaching नहीं होती है, anatomy, physiology, biochemistry. You must know about it. क्या होता है? It is called as a foundation course, and it starts with medical ethics and medical law. तो हम सारी चीजें बातें कर रहे हैं, वो सब उसमें होती है. So we have a lot to catch up. हम इसलिए फाइट कर रहे हैं आपस में क्योंकि हमें कानून नहीं पता है, और कानून नहीं पता है गलती किसकी है. कॉन्स्टिट्यूशन की नहीं है, पुलिस की नहीं है, पॉलिटिशियंस की नहीं है, हमारे लीडर्स की नहीं है, हमारी है. तो सबसे पहले तो हमको कानून के वो 180 घंटे पढ़ने हैं जो हमारे जूनियर्स पढ़ रहे हैं. प्रेशर्स पड़ रहे हैं MBBS के। That is one. Second aspect, just a moment. या आपने बताया कि जो असॉल्ट डॉक्टर्स को पर्सनली इतनी प्रॉब्लम्स होती हैं, इसके लिए भी जो अभी ड्राफ्ट आपने पढ़ा होगा 2022 में आया ड्राफ्ट मेडिकल एथिक्स रेगुलेशंस 2002 पे था पहले, जो नया आने वाला है इस साल शायद वो एक्ट बन जाएगा, तो उसमें द गवर्नमेंट हैज टेकन केयर ऑफ, द NMC हैज टेकन केयर कि डॉक्टर की जो पर्सनल इश्यूज हैं दे विल बी लुक्ड आफ्टर बिफोर गेटिंग टू द फाइनल जजमेंट कि डॉक्टर की नेग्लिजेंस है कि नहीं है इन ए पर्टिकुलर केस ऑफ कंप्लेंट बाय ए पेशेंट अगेंस्ट अ डॉक्टर. So we have a lot to catch up. We have got, the IMA headquarters. Dr. Sharad Agrawal, incidentally, is not here. He was supposed to be here in this session. 3 days ago, talks with him. He's a forensic guy, by the way. So we are planning a series of sessions for the IMA membership, so that we can learn law and we can fight ourselves. Because गलती उसने, मैं तो कहूंगा कि उस मेरी थी अगर मैं अर्चना शर्मा था, क्योंकि मुझे कानून नहीं पता, उसको तो बाद में बताऊंगा, पहले मुझे तो पता होना चाहिए कि अगर मैं जजमेंट हमेशा जेब में होनी चाहिए, क्योंकि ये मेरी अरेस्ट बचाती है फ्रॉम द पुलिस. अगर मुझे नहीं पता, हम सबको नहीं पता, तो हम बाकी सबको क्या बताएंगे. दिस इज माय टेक ऑन.
Take a message. We have to take the young generation. Yeah. Thank you, Dr. Chawla. Please. Please.
समस्या का जो सॉल्यूशन है ना, आप ये बताओ, अपने IMA प्रेसिडेंट को कितने लोग जानते हैं, जितने लोग यहाँ बैठे हैं?
अच्छा, चलो,
क्या कोई जानता है? क्या किसी ने वोट दिया उनको? पहले हमें अपनी एसोसिएशन को ऐसा बनाना होगा.
वही बता रहा हूँ.
2,000, 5,000, 10,000 डॉक्टर इकट्ठे हो सके. आज तक इतने मुद्दे उठे हैं, कितने नर्सिंग होम बंद हुए हैं.
डॉक्टर गुप्ता वही
कभी भी हमने अपना स्ट्रगल इतनी मजबूती से नहीं लड़ा कि सरकार हमसे डरे.
डॉक्टर छाबड़ा मैं कुछ कमेंट करूं.
अवेयरनेस मस्ट बी देयर. पब्लिक को साथ लेना पड़ेगा और यंग जनरेशन को हमें साथ लेना पड़ेगा. कौन बैठा है? मनीष बैठा है. यंग जनरेशन को जब तक साथ ले तो आप कुछ भी नहीं कर पाओगे. थैंक यू वेरी मच.
डॉक्टर छाबड़ा मैं
very big topic. We can discuss even 1 or 2 days. So, and I thank Dr. Rajiv Sood for. Want to say something, sir? Just
Yes,
one line,
yes.
sir, one line.
हाँ, मैं सिर्फ ये बोलना चाहता हूँ कि आज से 30 साल पहले जब एक बार मेंबर पार्लियामेंट आनंद अहिरवार ने एक डॉक्टर को स्लैप कर दिया था, तो उस डॉक्टर को हमारे एजिटेशन से, हमारे यूनाइटेड एफर्ट से अरेस्ट किया गया और उसको 6 महीने की जेल हुई थी. हम वो वाली सिचुएशन, जैसे डॉक्टर त्यागी ने भी बोला, क्यों नहीं क्रिएट कर सकते. ये जरूरी नहीं है हमको डायरेक्ट कन्फ्रंटेशन करनी है, पर हमारे को अपने यूनाइटेड एफर्ट से अवेयरनेस लाने के बाद, अब मैंने ये देखा है कि IMA में ये बहुत बड़ा इशू बना और सेमिनार्स हुए, वेबिनार्स हुए और उसके बाद इसके बारे में बात करनी बंद हो गई. तो ये एक कंटिन्यूटी दूसरा फैक्टर है, कंटिन्यूटी चाहिए. और तीसरा जो नॉलेज की बात कर रहे हैं, वो नॉलेज के बारे में मैं ये बोलना चाहता हूं कि ये नॉलेज होना ही काफी नहीं है, कंटिन्यूटी भी बहुत जरूरी है. हम किसी एजिटेशन की पीक पे जाके टीवी प्रोग्राम की तरह आज एक मुद्दा सामने है और जब दूसरा मुद्दा आता है तो पहले को भूल जाते हैं. अगर हमको ये मुद्दा कंटिन्यूटी में रहे और अपने जो पॉलिटिशियन डॉक्टर्स हैं वो भी थोड़ा सेंसिबल काम करें और डॉक्टर्स के लिए सोचें, तो हम इसको कंट्रोल कर सकते हैं.
Thank you very much.
For the nice words. Now in right chairpersons to honor Dr. Ram Chhabra and Dr. R.V. Singh, please come and honor our chairpersons. And next time we are running late, so I think we shouldn't waste much time. So next topic is diabetes. And for this we have to speak here. He will be online. Dr. S.V. Kulkarni is the chairman of API Navi Mumbai City chapter. The chairpersons for this is Dr. Atul Gupta. Atul Gupta, please. Dr. P.K. Goyal. Dr. P.K. Goyal. हाँ गया P.K. कहाँ गया? कहाँ गया? नहीं है. Dr. Anil Jain. Dr. Anil Jain, please come. Dr. A.K. Sureka. Dr. A.K. Sureka is senior physician practicing Rohini. Dr. Anil Jain is also practicing Rohini. Dr. Sureka, please come, sir. Chairpersons, please come. डॉक्टर सुरेखा, क्या हो गया? अरे यार, पानी आ गया, प्यास लग गई। सुरेखा साहब, आपको नहीं? डॉक्टर के मल्होत्रा, प्लीज. डॉक्टर मल्होत्रा सर, यू प्लीज. हाँ, डॉक्टर गुप्ता. Now, chairperson, please start the proceedings. Dr. Kulkarni is on the line.
Good afternoon, everybody. Now we have Dr. S.V. Kulkarni. He is chairman API and he is online, and he would be online from Navi Mumbai, and he would be speaking on has CGM, that is continuous glucose monitoring, changed the scenario of diabetes management. Sir, you can start, sir.
Thank you very much. Am I audible and am I visible? Please, I will request the
Yes, sir.
monitor to allow me to share the slides. The host, I have been disabled to screen share. And thank you, Dr. Chabra and all the physicians from North Delhi Physicians Foundation. It has been almost, I am seeing so many good familiar faces in the audience. And this is something new topic which I'm going to discuss. But the discussion is going to be flowed in a manner that from tomorrow onwards, you will be in a position to prescribe a CGMS to every patient. So can the host allow me to share the screen?
Yes, sir, you can.
Is my screen visible?
Yeah, it's clearly visible.
It is visible? Okay. Thank you very much. So thank you, Chairperson, for the wonderful and brief introduction. I represent Navi Mumbai, and I was organizing secretary of APCON 2007 in Goa. And my blood is nowadays replaced with technology and medical future aspects. I'm very deep into the technological aspects of clinical medicine. Dr. Chabra asked me one question, that how CGM has changed the scenario of diabetes management. And my answer to him was CGMS, that is continuous glucose monitoring system, is a sweet dream for diabetes management. After insulin, this is one of the best steps which has happened to diabetes. How it works? It acts like a detective in your body. How the food raises your sugar? What are the patterns? With carbohydrates, different kind of proteins, fiber, fats, oils, high fructose drinks, a very common thing in all our residents and youngsters. And how your exercise or walk or your weight training helps to drop it. How yoga, meditation, pranayam helps you out. Just take one simple example, carbohydrates. If you are eating your breakfast with 5 different carbohydrate things in every morning, you will come to know how your blood glucose is rising. I give my patients a very simple example, that what you will like to prefer. You will like to prefer a tire puncture with a failure, or you will prefer a car which has got something called as a continuous tire pressure monitoring system. It is coming to almost all the models nowadays. So it will give you sense of a danger ahead in management of your diabetic status. Or the second example which you can give to them, that the finger prick sugar is like a ECG at that spot, and CGMS is like Holter. So it indicates, it picks up the dangerous arrhythmias of your life, and it can help you in getting properly treated. Or in a very simple way, it can be a reality check ahead. that you may be looking, you may be imagining that your sugars are very well controlled, but in fact, it is not. So if you want to tell your patient, you please tell them that it is a small wearable device that tracks glucose levels about every 4 to 5 minutes, day and night, almost to the extent of 250 to 300 readings every day without a single finger prick. It notifies you about highs and lows. The wire sensor, which is very simple. I don't know whether you can see it on screen on the video, but I'm going to show the two types of sensors which we are using. And it measures the glucose levels into the subcutaneous or the interstitial fluid, and it is connected to a transmitter that sends the data to a monitoring and display device. So this is in brief, this is the transmitter sensor, and here you can see the thing going into the interstitial fluid. And there are two types of systems, either professional or personal. There can be real time or intermittently scanned, or previously called as a flash technology. And this CGMS can be connected even to a insulin pump. In fact, it is one of the essentiality that all insulin pumps nowadays, they come with CGM, so that the body senses the glucose and delivers the insulin accordingly. There has been big evolution. This we have been seeing in Indian market for last so many years, and we have got some other alternatives also. This Freestyle Libre, the second variety, where you can actually see the direct reading of the sugar. Or this is one instrument which I have used in last 2 months. It is from IDEX. It is a CGM from IDEX. It has got a 4-year reusable transmitter. What I am holding in my hand is a 4-year reusable
Dr.
transmitter.
Kulkarni, please, slide not moving. Please, Dr. Kulkarni, please.
Slides are not moving.
Slide not moving.
Just a minute. I will reshare it. Are they moving now?
Yeah.
Are they moving?
Yes.
Now they are moving.
Again, go on, sir. Again. Again, share, sir.
Yes. Is it seen now? You can see the detective.
No, the slides are not visible.
It is there. So it acts like a detective within your body, and it tells you how the body reacts to the various foodstuffs you are taking. Always give an example of a flat tire versus a car which is using the continuous tire pressure monitoring system. Or we give an example that ECG is
Dr.
finger stick.
Kulkarni,
Yes.
share your slides. Please share your slides.
Slides are not moving again.
Yeah, not visible.
Just a minute. Please give a minute. I will close the presentation. Is it okay now?
Yes, sir. Yes, sir. It's okay.
Is it moving?
Yeah, moving, sir. Continue.
Yeah.
Continue, please.
Yeah, this is the detective.
Okay, sir.
And this is the flat tire system, which is tire monitoring, and this is your ECG, and these are the different arrhythmias which you can see and which you can treat. And the patient is really convinced that when you compare his arrhythmia to hypoglycemia, or sometimes the picture can be as odd as like this. So this is a very compact way in which you can explain the patients that how a CGMS works and how the CGMS acts. If there is a transmitter here, it goes to the interstitial fluid and then it records, it gives the signal. These are the various type of systems which are available. This we are using for years together, 2-3 years. And now recently I have used this system called as the IDEX. This has got a 4 years reusable transmitter, which you can see here. It is, the label is Oxymed, and this is the CGMS of AIDEX, and this is the CGMS of Abbott, which we use in our day-to-day practice. The CGMS advantages are very, very significant. Most important, it relieves the patient of different kind of finger pricks. Now, my patient, he has got this kind of graph on the CGMS. Within 70% of the time, I can say confidently he is within the target range, 70 to 180 milligrams. He is in hypoglycemia only for 5% of the period. Above 180 is only 25, and above 250 is with the 5% time duration. This I would not have been in a position to tell him otherwise without a CGMS. It relies upon quarterly visits to HbA1c check. It neglects the reality of life with diabetes, that is continuous. It is a dynamic process always. Using HbA1c alone may not be very helpful. You cannot assess the impact of lifestyle, no visibility of the response to intervention in a short time, and patient may be reluctant to advance therapy if they don't understand the glycemic pattern. And blood glucose management and notable limitations. At a single point of time, the patient engagement and use is impacted by associated pain as well as social stigma. Today, I am in a conference. I want to check my PP sugar. I cannot check it with the audience. The majority of the diabetes care transpires between visits outside the clinical encounters, but wearing a CGM allows your personal discovery as patients engage in their own care. So here you make the patient responsible for his own care. This is a typical patient of mine. His only complaint that he used to feel very odd after exercise. And then what we found that he had post-exercise delayed hypoglycemia, which was very significant. What was the intervention which we did? We asked him to consume complex carbohydrates before he started doing his exercise around 4:30, 5 o'clock. And then this dip which was seen on this graph, that completely disappeared, and that I would not have been in a position to see with that CGM. And at the same time, if you can see here, he had significant amount of asymptomatic overnight hypoglycemia that was reflected by very bad dreams, very early morning headaches, and sweating, which all replaced when we gave him complex carbohydrates in the evening before his exercise. There are many advantages, but when you talk to the patient, we have to tell that it's a very simple device which has been approved. And who will benefit? All the patients of diabetes, and they will be definitely patients who will make a lot of changes in their lifestyle depending upon the blood sugar response. These are the different kind of patients, the patient who struggle to meet glycemic targets, to people who are using continuously on insulin pump. Hypoglycemia or fear of hypoglycemia is one of the biggest problem associated with management of our patients, and then people go on defensive eating and they increase their weight as well as their weights. This is the time percentage what a healthcare giver spends for the patient during his 1 year of contact. But if you do CGM is spending 14 hours continuously with the patient. The question asked is, how do I start? Best is use an interprofessional approach. Means you know the patient for a long time, you know the disease. Just tell him that this is going to be a good friend in between. There are local people who present the CGM systems. You can use some free samples. These ambulatory glucose reports generate the changes which are there and prepare to adjust medication in patients who are more involved in their own care, and at the same time demonstrate positive results from exercise and dietary counseling that really helps like anything in all our patients. So these are lot of different kind of models. You can read these references whenever you are at your leisure, and I'm going to share this presentation with you. These are the small signals what we see. What does up arrow see mean? It is the sugar is rising very quickly. This means it is going about 2 o'clock position, it is rising. It is changing slowly, it is falling, and it is falling quickly. Means these two are the times when the patient has to take care of his sugar supplement, and these two are the times when he has to act as far as his carbohydrate contents or the diabetic medications are concerned. Our patients become very smart once they start using this. See this example. I have got a CGM reading and I have got a blood glucose monitor reading. I am missing this hypoglycemia. I am missing this hyperglycemia. And this is the only way in which you can understand the hypoglycemia and hyperglycemia. These three patients have got a HbA1c of 7, but see the glucose excursions which are possible only with CGMS. The blood glucose monitor does not provide trends, rate of range or alerts, but CGMS provides it. People forget to check. Blood glucose monitor devices do not alert immediate or impending high-low glucose unless you are using with attached a smartphone app. And single glucose values can be widely skewed or by the unwashed hands. So please remember, there are certain things which we should tell to our patients, that there are a lot of factors which affect blood glucose values. Hand washing, residual detergent, the strips which are not stored properly, batteries low or about to die, mismatch of the strips, meter to some same make, different model, someone is wrong and they start blaming us. You are wrong, aapka galat hai, or your meter, your laboratory. And at the same time, there are 42 different factors which affect your fingerprint blood sugar. So let us not go into the detail, but let us see some of the examples of CGMS. So this is the applicator, and this is the place on which we can see the results. The Abbott requires a special reader, but IDEX you can do it on the smartphone. So what are the participants respond? And these are the perceptions. It contributed to healthy lifestyle, 90%, modified the nutrition choices, 90%, because the patient knows कि मैंने सुबह छोला भटूरा खाया है, मेरा sugar speed up हो गया. If I eat more salad with it, that will not go. And they will be more likely to walk or exercise in response to the normal glucose values. That is a very good addition, and it increases the quality of life of the patient. The same of the human being and the quality of the patient is very important. Yeah. Very important. And this is the report what we give, and what is the most important report for the patient? That is time in range. And with these graphs, you can always explain to them that these are the three distinct sessions. The summarized glucose values show variability, and it can show single day glucose values to identify pattern and progress. Let us go back to the first slide which I showed. This is a time in range, which is almost by 70%. I request him to adjust his sugar intake, his food intake to low carbohydrates, high fiber, and I think he can definitely go to almost 80%. So these are the different kind of, this is the pre-treatment. After 7 days monitoring, I shifted the patient with single basal shot of 10 units of Lantus, and then you can see the flat glucose, which is within the normal limit. These are the ways in which we can ask the patient to adopt insulin very, very fast. So these are the last very two important slides. I have mnemonic as ICC, that identify, right technology, right person and right time, configure it, data drive conversation, share decision making. The care team, you require one person from the family to help them and collaborate. And the second thing is the data. Download the data, assess the safety, time in range, areas to improve, and action plan. References. This is one very good reference, glucose as a fifth vital sign, and I am sending to Dr. Shabra a list of different references and presentations which you can show to your patients. So friends, it is a time of artificial intelligence for the future of mankind. It offers a remote digital solution. It provides continuous individualized feedback for rapid intervention, allows intelligent modification of pharmacotherapy, and it requires ongoing validation to some of the newer equipments which are coming. So So what are the pulse and tips? Reduces hypoglycemic event, improves hyperglycemic event, and totally simplifies the process. So this is the summary. Blood glucose monitoring with finger stick has got limitations. Real-time CGMS is helpful for both type 2 and type 1 diabetes, and it can be a very useful tool for the management. If you want some more references, this is the CME by Medscape. It will explain you the whole process, and these are the further readings and references. They are from ACE as well as from our own RSS DI. And this is from the last one is from the Standards of Medical Care of ADA. So friends, the answer to Dr. Chabra's question is, has CGM has changed the scenario? 100% it has changed the scenario. It is worth adopting in your practice. It will make a big change in your practice and caregivers like. So please be a leader and please be a part of a real help to the patient with management of the lifestyle disorders like diabetes. If you need these slides or references, you are most welcome. And I thank Dr. Chabra for giving me this opportunity. And I'm really sorry for the initial technical hassles, because I'm right now speaking from a remote place where the signal strength is very low. Thank you very much. Dr. Chabra, I am stopping the slides, but I would like everybody of you to start using CGMS. See, it is like cycling or swimming or horse riding. When you are swimming, you have to go down the water. If you are cycling, you have to fall down. And if you are horse riding, then you have to be thrown out at least once.
Thank you, sir.
the
Thank you, Dr.
hospital.
Kulkarni, for delivering nice talk on the CGM technology. But issue of the CGM technology, the availability and the cost. Okay, and this is the availability. They are not able to every center and clinic. So big issue of the availability. And what is the chances of error in case of monitoring of the case? It is also wonderful in cases of the brittle diabetes or the renal impairment of the patients. But
Yes.
what is the chances of the error?
Yeah, there are chances of error because it doesn't measure the blood glucose. It measures the interstitial fluid glucose, and you may have to take once or twice when you are using the Abbott system. Same time, you see, take the blood glucose by the finger stick, you will find a difference about 10 to 15%. But the second system which I showed, the IDEX one, there is a possibility of modifying your readings. So you can match your readings to the machine reading, and you please see the videos of these machines, or you ask their representatives to show you. There are many of the times they do it free for the physicians for the initial time, and the reader costs around 5,000 for Abbott Freestyle Libre. The older one costs around 3,000, but the IDEX one cost is still less, and it has got a 4 years warranty for the transmitter. My request to all of you is, please start adopting technology as early as possible. Because otherwise, if you don't adopt, those people who are adopting are going to take over for you. If you are prescribing a glucometer, prescribe a glucometer which has been connected to an app. Example, AccuCheck Instant. It is connected to an app called as the My Sugar. So it shows you the up and down of your blood sugar. You can keep a food diary. It can become a semi-CGMS for your patients within, say, 2,000, 3,000 rupees of it. Please try adopting this technique. Get the time in range for your patient, and your patients will bless you because you have shown them something which is really wonderful, real time and live.
Thank you.
If you are interested to know more about it, in the Ahmedabad API, I am going to have workshops on this, and I can show you all the demo systems, demonstrations. And if the company stall is there, then they will even put you a free sensor and a free reader also for that, so that you yourself come to know what is the beauty of this machine.
Thank you, sir. Thank you, sir. for
Metabolic endoscopy.
And please,
Thank you, Dr.
so much, sir.
Kulkarni, for a practical insight and online teaching of CGMS. Thank you. Thank you.
Thank you. Thank you very much. Thank you, Dr. Chabra. I am sending you the presentation.
Dr. Tripathi to honor our chairpersons. And next is now respiratory session. And the topic is endobronchial ultrasound, a new kid on promotion. And the speaker is Dr. Rakesh Chawla. And chairpersons are Dr. Amit Jindal. Dr. Amit Jindal. Dr. Amit Jindal is senior consultant, Fortis Hospital, Shalimar Bagh. Dr. Aditya Chawla. He is a budding respiratory physician. Dr. V.K. Singh. Dr. V.K. Singh, please come. He is a senior physician practicing in Rohini. And Dr. Pankaj Gupta, I think could not make it because of some reasons. So I request the chairpersons to introduce the speaker, Dr. Chawla, and start the session.
So Dr. Rakesh Chawla, he's a well-known senior consultant at Saroj Super Specialty Hospital and Jaipur Hospital, and he's going to speak on eBus, new kid on the block for promotion.
Thank you. Thank you, Dr. Chhabra. It is his courtesy that I am here. Even never mind, it's a spirit that I have been given this opportunity. Thank you, Dr. Chhabra. The doctors have to change their attitude of Manuki. It has to be changed. If you should be united and those things are not there, we are the biggest hypocrites. We talk different, we behave different. Same Tyagi Sahib is different here. Same Tyagi Sahib is different when procession is going on. Of the same minister to him is criticizing. So we are hypocrites. That's why society does not care for us. If the teacher and the doctor needs protection, it is a shame on the society. It's a society responsibility to protect us. And now where we are, we all understand. Anyhow, I am going to talk something new to the physicians. I wanted more number, and I think it's going to be enlightening to you what I am going to talk. We all know about a bronchoscopy. It's a second eye of a chest physician. That where these days we don't expect a general physician to refer a tuberculosis, an asthma, or COPD, or an ILD. They are self-sufficient and they are able to manage to considerable extent till they are beyond control, like asthma, difficult to control, COPD exacerbations, end stage, ILD, end stage. Yes, where we come into the picture. But when it comes for the diagnosis, the bronchoscope, is to visualize the airways. I am going to talk today about eBus. It is a bronchoscope with GPS. Where is the post office? I don't have to ask. I know where the lymph nodes are. I can visualize them and I can puncture them. In the country of 140 billion, hardly there are 300 eBus in the country. And we have in our Saroj Super Specialty Hospital, and in Northwest Delhi, we have in Rajiv Gandhi Cancer Institute. Patients are always inhibited, a benign disease, to go to the Cancer Institute. Linear probe eBus, seeing is believing. When you practice it, you appreciate what it's a game changer, how it has changed the game. In our area, we have one in our hospital. This is how the tower of eBus looks like. This is the normal bronchoscope through which we do the normal bronchial biopsies. We are visualizing the airways. It makes a difference and make it very, very expensive, putting an ultrasound probe on the tip of the bronchoscope. And you can see the needle coming out at 35 degrees at an angle to puncture the lymph node. This is the probe. When you touch to the airways, you are able to see the mediastinum, the great vessels, and the lymph nodes. This is the anterior end where there is an ultrasound probe which we play with and visualize inside the structures beyond the mediastinum. This is a linear probe, then we have a radial probe EBUS, which we take help to diagnose the peripheral opacities, metastatic tumors, lung nodules, so that we are able to, and this radial EBUS is with a transducer which rotates at 360 degree, and we create an image in the periphery of the lung, helped by the C arm, and we are able to puncture the peripheral opacities with the radial EBUS probe. It is a very essential tool for a pulmonologist today. This is the third eye. Second eye is the bronchoscope, and this is the third eye. If you visualize this picture, you say the bronchoscopic view is absolutely clear. Airways are all clear. There is nothing, bronchoscopy is normal. No, the patient has the necrotic lymph nodes. How you will visualize them? This is where the EBUS comes into picture, and you are able to create an image, puncture, and able to see the character of the lymph node. So you must choose why you need a bronchoscopy, why you need an EBUS, why you want a linear EBUS or a radial probe EBUS. So you must choose them to practice. Primary indications for TBNA, we know it's a lymph node, mediastinal lymphadenopathy. It is a tuberculosis, it is a sarcoidosis, it is a CA lung, it is lymphoma, or it helps in staging of lung cancer, mediastinal tumors, solitary pulmonary nodules, and endobronchial tumors. Now, as a physician, for you, it's very, very easy. Patient hai, mediastinal lymph nodes hai, TB hoga, chalo TB ki dawai shuru kar. You know there are hardly any side effects of the tubercular treatment, but you will hesitate to start steroids after seeing the lymph nodes. So you need a diagnosis. A dilemma is always there between tuberculosis and sarcoidosis. The only thing which differentiates is an FNAC. And you are able to see the histopathological picture, and you are free to start. A treatment is far apart, the steroids or the antitubercular treatment. So the patient has a right that you must tell him the diagnosis. And diagnosis on this earth can only be made with the TBNA, either conventional TBNA or the EBUS TBNA. Whenever you are practicing not only bronchoscopy, an interventional bronchoscopy or an EBUS, this picture should be imprinted in your mind, because everything is crisscrossing the carina and the drama played at the manubrium sterni. First year, anatomy, McGregor, the question used to be the drama played at the manubrium sterni. And this is the drama where the aorta is crisscrossing the pulmonary artery, the superior vena cava, the inferior vena cava, innominate vein, azygous vein, they are all crisscrossing around these lymph nodes. So you have to be, when you are puncturing these lymph nodes, you have to be very, very careful. And EBUS, you can have EBUS and mediastinoscopy to have an access of these yellow colored lymph nodes, the station 2, 4, and 7. Mediastinoscopy is obsolete these days since the EBUS has come to the picture. And you can puncture with EBUS, which are not accessible even to mediastinoscopy, all hilar lymph nodes. Those who are not accessible to EBUS are station 5, 8, and 9. Now the same EBUS scope we pass through the esophagus. We call it as an EUSB FNA, and we are able to access even supraadrenal lymph nodes, and we don't need a gastroenterologist to puncture these peripheral lymph nodes. So virtually all lymph nodes are accessible with the EBUS. So if you combine with EUS and EUS-BFNA, you are able to have an access to all the stations. As I told you, TB and sarcoidosis is very, very important. Both are granulomatous diseases to differentiate from each other. Even the lymph node characteristics, if you will start visualizing with the experience, you know this lymph node is appearing like sarcoid, or this lymph node has a necrotic structure and is looking like tuberculosis. Even physiologically, you can make a difference. If it is rounded without intranodal vascular structure, you know it is a malignant lymph node. This is a case which I am sharing with you of the mediastinal lymphadenopathy. And this is the paratracheal lymph nodes, which are, if you go by this X-ray, 70% of the people will pass it as normal. The X-ray does not have any parenchymal opacities, but patient has got a paratracheal shadow. A CT chest is showing you the mediastinal lymph nodes. Now, what is the diagnosis? It's tuberculosis. So, patient will be started on ATT empirically. But if it turns out to be sarcoid, 3 months are gone, there is no resolution, the lymph nodes are, or it is malignant. So it is your right that you must know the diagnosis when the investigations are accessible to you. I'm showing the glimpse of how we do this procedure in a bronchoscopy suite under conscious sedation. Now, each lymph node we do 3 to 4 passes. If I am doing station 7 or station 4 or station 10 or station 11, and then we have a ROSE, rapid on-site evaluation. The moment we finish the procedure, we make the slides, and we see we have got the adequate material to have the diagnosis. And if you see how we do it under conscious sedation. So we have already localized the lymph nodes, we have done the whole procedure. This is the EBUS TB and a needle, and we are able to puncture, and you can see the margin of the lymph node. We are clearing with the stillet the internal edge, whatever debris have gone in when we have punctured the needle, and now we will be doing the jabbing movement from wall to wall of the lymph node, and you can see down a pulmonary artery where you need to be very, very stable that you are not puncturing the vessel, and you are able to get the sample by jabbing the lymph node. This is what we call it as a pass. So this is the single pass in a lymph node, and average every lymph node we do 3 to 4 passes to have the diagnosis, and we take it out. Once we have taken out, we take out the core sample of the lymph node and to prepare. So you see how the core is taken of the lymph node, which we have taken, which we call it as a cell block, and send it for histopathology. Now you can see the core of the lymph node has come. And once the core is clear, we will prepare the slides. Slides are prepared. This is all done inside the bronchoscopy suite. You can see the core of the lymph node, which we have retrieved, and we send it, we call it as a cell block. Now the slides which we have, we prepare them, we fix in alcohol, giving it 10 dips into the alcohol. Then we give it into the field stain B and field stain A. These are the quick dip stains. We prepare the slide inside the bronchoscopy room. When the procedure is going on, the whole process takes 1.5 minutes, and the slide is ready to be seen by the pulmonologist himself that the material is adequate. We wash it, we dry it, and we put it to visualize and then send it to the pathologist. This is the station where after the slide is prepared, you see the material you have aspirated is adequate. Now you need not make a diagnosis. Let pathologist make a diagnosis. With the period of time, you start recognizing, you start thinking, these are granulomas, these are cancerous cells, these are non-caseating granulomas, lymph node material is there, reactive lymph nodes are there. Gradually, with the experience, you pick up everything. And in another 2 minutes, pathologist tells you, yes, the material is adequate. And she tells you a diagnosis in 2 hours to 3 hours maximum she takes and gives you. Diagnosis is not done in 2 to 3 hours. It's an excuse of the pathology. Sir, बहुत सारा काम है. मैंने ये देखना है, slide देखनी है. चलो कोई नहीं, you take your time, madam, and tell us the diagnosis. The same patient, when we have visualized, it is a sarcoidosis, non-caseating granulomas. You can see the multiple granulomas, and it has come to be the sarcoid. This was serum angiotensin converting enzyme.
Can we summarize?
Okay, Mantu's negative, gene expert was negative, patient was started. Apart from this, we look, these are fourth eye beyond mediastinum. Even if the peripheral opacities are there, we are able to puncture them and we can have a diagnosis beyond mediastinum, even the pulmonary opacities where the bronchus is leading to them. Even in children's, it can be done. Under general anesthesia, same EBUS scope through esophagus, you can sample the tumor emboli, you can have a transaortic puncture. It is a new, minimally invasive, safe and highly accurate method with 90%, 95% specificity and the sensitivity. The experts in anything was once a beginner, and you can refer us. And if you are looking for some concession, have this number director of Saroj Hospital, so that he is ready to welcome any query and is going to welcome all your referrals and whatever is the condition of the patient, but you must give that benefit to them. So thank you very much.
Congratulations, sir, for wonderful talk on EVAS. No doubt, it is very good and safe procedure, but how can we make easy and affordable to more and more patients? Because cost of the still 25,000 is the big issue. So
See-
as per physician's perspective, if patient match with clinical history and X-rays and other, then we will try and other laboratory tests. So we'll start only as a clinical background, tubercular, if any doubt. So why before starting, if it become more affordable and more cheaper, then we'll try to get the definite diagnosis to give by this method. So how can we make any using the disposable, etc., or the minimum cost?
See, if we reuse the needle, the fresh cost of the needle is 12,000 rupees. That's the cost price of the needle.
Okay.
And if the patient is a CGHS, DGHS, ECHS, they give you 18,070 rupees, inclusive of everything. So it is a no cost procedure when you are doing in panel patients. The question of cost comes into the cash patients.
Okay.
So if you say we do not want to pay, we reuse the same needle 2 to 3 times. After properly cleaning it, the same needle we use in all panel patients which are CGHS. Then that's why I shared with you the number of the director. You are looking for some discount. You call me, you tell him. But whatever, if you feel the instrument of 1 crore and 10 lakh of rupees is at your center, the price in the whole country is anywhere between 35,000 plus whatever is the investigation. It is 30 to 35 everywhere. And you are looking for, no, my patient is poor, truly poor, and this much discount should be offered. The hospital has opened that portion and the discount will be given.
How much, sir?
See, now you think this patient should be given 20%, should be given 30%. You take it, send the patients.
And
If he will not, I will give.
any hazards to patient for
Zero.
reusing of the needle?
No, reusing of the if you go by international literature, reuse of the needle is not recommended. Now, CGHS patient, 18,000 rupees, what you will do, what I will get, what hospital will get, what the system will get if I start using a fresh needle every time. This is the truth. If I say, no, I use every time, I open every time, you don't come to check it there. But the सच्चाई यही है कि वो needle reuse होती है, वहीं आप 18,000 में compensate कर सकते हो. And if you want discount,
thank you so much.
we can make your CGHS billing 18,000. Then don't talk of कि सर आपने needle नहीं use किया, आपने ये नहीं किया. आ गया? Thank you very much. ना मैं तो बोलता ही रहूंगा.
Thank you, Dr. Chawla.
की तरह सच बोलेंगे.
I request the chairpersons to honor Dr. Chawla and Dr. Rakesh Sood and Dr. S.K. Arora to honor our chairperson. This is the last session. And there's a prize or lucky draw after this session from this topic. So next topic is by Dr. Nityanand Tripathi. Doesn't need any introduction. He is a director and head cardiology and electrophysiology at Fortis Hospital, Shalimar Bagh, renowned cardiologist. The chairpersons are Dr. Rakesh Sood. Dr. Rakesh Sood, sir. पहले उधर आ जाइए सर, फोटो बाद में. Dr. Rakesh Sood, Dr. B.R. Chavda, I think it's gone. Dr. Rajiv Diwan, you please come for the session. Dr. Sandeep Miglani, कितने बार बैठेगा ये, उधर ही बैठने दो. मैं हूँ यहाँ पर, मेरा भी है. I am also the chairperson. I am also the chairperson. नहीं इधर देखते रहिए.
Good evening, chairpersons. I am really very thankful to NDPF who have given me opportunity not once, twice to start the session and to end the conference as well.
You are the opening and the last batsman both.
Sir. So I will not take much time. I will wrap up in 10 minutes. Try to wrap up in 10 minutes. So device therapy of arrhythmia, physiological pacing, basically bradyarrhythmia that I am going to describe in this talk. From its human implantation in first implantation in 1958, the pacemakers have saved life of millions and millions of the people. Within 1 decade, it became clear that non-physiological pacing has several hemodynamic disadvantages. Contemporary thinking led that let's pace atrium and ventricle both and sequentially, that is DDD or DDDR, that will be more physiological and will decrease the hemodynamic bad effects of the single chamber pacing. The term physiological pacing was used first in the Canadian trial of physiological pacing, and the dual chamber pacing was done, and RCT was death physiological, that is heart failure and atrial fibrillation was seen, and there was no difference in fact in the both group whether it was single chamber or dual chamber pacing. The main adverse effect of the RV pacing was it is slower conduction, that is myocyte to myocyte propagation, and there was LV-BB morphology since we are pacing from the right side. So septum gets activated first and lateral wall is getting activated last. That's why there is a dysynchrony, and the whatever energy which is there in the heart is not getting utilized effectively. So the load of the LV dysfunction, that is LV dysfunction that happens, it happens because of the right ventricular pacing, and if right ventricular pacing is persistent, patient develops LV dysfunction very early. So what is people then moved on to the physiological pacing, and they thought why not to pace the hinge bundle itself. But hinge bundle pacing had a different distinct disadvantage because most of the times we have the CHB which happens in mid of the hinge or lower of the hinge bundle. But when it happens in the upper hinge bundle, it becomes very difficult to recognize unless you do electrophysiological study. The second one is if it happens below the conduct, that is bundle of it, then pacing the hinge becomes useless. Moreover, hinge is a fibrous structure, and if we put our lead inside the hinge, then our threshold remains very high. The average threshold that we get is 1.5 volt, and more is the threshold, and patient has to get another replacement very soon. It has been shown it is feasible, but adverse effects are higher pacing threshold that I told you, and proximity. It is proximal in proximity to the tricuspid wall, so tricuspid regurgitation happens, and there is a chances that the lead might get dislodged, and that happens almost 8% of the cases, and lead revision is there in 8%, and in fact, free from any complication happens in only 91% of the patients. But we know that by now that it is left bundle branch block which is actually producing the left ventricular dysfunction. So idea came that why not to pace the left bundle itself. So we started pacing left bundle branch, and this is left bundle area pacing. And the many studies has shown that left bundle area pacing is equivalent to hitch pacing, and in fact better than that because the leads are stable. The early reports came from the patients who have cardiomyopathy with left bundle branch block, and when we pace the left bundle, the LVEF improved from 32 to 62%, and it was proven in multiple studies, initially small studies, that there is significant improvement in the LVEF in these patients as well. So the left bundle pacing not only prevents the future LV dysfunction, but in fact it improves the LV dysfunction which was already there in these patients. And I have done the left bundle pacing in 50 patients, and almost 30% of them had been severe LV dysfunction, initially coming every often to the hospital. Now they are fine, and their LVEF have improved significantly. So there are 21 patients to 93 patients experience has been there, and there is good success rate initially up to 90%. I will show you the largest trial that has happened in the patients of 632, and with 2-year follow-up, 97% left bundle pacing success rate has been there. Pacing was stable, and QRS duration has been achieved up to 118 milliseconds. That's the normal, from almost 170 milliseconds. And this is significant. LVEF improved from 33 to 35%. So patients with the LVEF of less than 35% do have increased chances of dying suddenly, and there we require a defibrillator function. And if we do just left bundle pacing, the EF improves drastically, and these patients becomes normal. The symptomatically, quality of life and longevity as well. The left ventricular end diastolic and systolic diameter also decreases, and this is where we pace. This is the AV node. This is hitch bundle, and this is left bundle where we pace, and the conduction becomes normal through the left bundle hitch Purkinje system. I will share one or two of my cases. This is 56 years old male diabetic. You can see white QRS, and once I put this is the RV apex, and here we put the proximal septum, and this is the left bundle lead that we are putting, and once it is there, then you can see this is normal QRS. The final QRS becomes quite normal. It's 120 milliseconds. Likewise, this female patients with the low EF, we did the left the CRTD, but CRTD did not correct the left QRS. And once we did the left bundle pacing as well with the CRTD, this is known as hot CRT. So you can say QRS, initial QRS was 184 milliseconds. The QRS came down to 119 milliseconds. It's normalized completely. And in these patients, the EF improved from 20% to almost 40%, 42%. In last 6 months, there has been no hospitalization in these patients, but and previously it was frequently hospitalized. And this was done I did this case in the Banaras. It's the same case, lot CRT, and you can see the only left bundle pacing, there was QRS is still wide. When only biventricular pacing, that is CRTD pacing, QRS is still wide. But when we combine both technology, the QRS becomes completely normal, 120 milliseconds. This patient also had a significant improvement in the EF. This 20% EF has become 45%. Patient is doing all his functions routinely. So to conclude, left bundle branch pacing is a novel pacing modality that can bypass the physiological disease vulnerable region in the cardiac conduction system, provides physiological pacing modality for the patients. Left bundle pacing guarantees narrow QRS, and left bundle pacing can be applied to circumvent the limitation of each bundle pacing and RV pacing. It is potential alternative for CRT in patients who cannot afford it. CRT cost anywhere between 8.5 to 12 lakhs, while left bundle pacing can cost the patient around 2.5 to 3 lakhs. Thank you so much.
With the availability of CRT, now it is a game changer for many patients who have bad ventricle, or patients who have left EF less than 35%, and particularly those patients who have normal coronaries and bundle pattern. These patients do benefit. We have seen a lot of patients whom we have given CRT, they have improved dramatically. And the quality of life improves. The recurrent hospitalization has also gone down. So this is a boon for patients who previously we used to have a single chamber. Now with the availability of CRT, we are able to give more physiological pacing to patients. They really benefit in those patients who have normal coronaries. Particularly, it's very beneficial in normal coronaries where we've seen patients coming with ejection fraction 20-25%. After 6 months, they are going back to normal. So it is a really game changer. Though the cost factor is there, but I think with the availability of new pacemakers, the cost is coming down and more people are going to get benefit from this.
Yes, sir. Actually, this is something different from the CRT. That is, in CRT, we are pacing from through the coronary sinus to the left lateral side of the heart and septum as well from the right, from the RV lead, and we a little bit delay the RV lead from the left so that the synchronization happens. But synchronization does not happen always. And when we are utilizing the conduction system, then conduction becomes normal and physiological, because Purkinje is the left bundle is dividing into Purkinje system, which is supplying to almost every myocytes. While when you are pacing from left side or right side, the conduction becomes myocyte to myocyte, which is slow. So it is much superior than the CRT pacing.
Then how many patients of ventricular tachycardia have you tried for this to overdrive pacing for these patients who have?
So this is not for the overdrive pacing. The patients with the ventricular tachycardia, what we are putting the defibrillator lead in the right ventricle, and this is the pacing technology. We are narrowing down the QRS and synchronizing the whole myocardium. So EF becomes normal, and if there is a VT, then the lead that we have put in the right side, that is the defibrillator lead, that will defibrillate the patient.
It doesn't contain the.
So patient will have the best of the both.
No, it doesn't have the defibrillator, this device.
The LOT CRT and hot CRT has the defibrillator, while only when we are pacing the left bundle, that will not have a defibrillator. So if patient has EF of less than 30%, we are giving defibrillator as well. And if patient cannot afford, we can give just, in those patients, we are giving CRTP. It's a useless CRTP now. We can pace the left bundle, and the patient will be fine in 2.5 to 3 lakhs, while CRTP will cost almost 5.5 lakhs. There is no defibrillator function in CRTP.
But defibrillator is important because these patients are prone to ventricular arrhythmias. The dilated cardiomyopathy.
Yes, sir. That's why we are pacing with the defibrillator. That is LOT CRT that we are giving them. That is left bundle optimization CRT, where we are pacing the left bundle to make the QRS narrow and synchronize whole ventricle, and giving the defibrillator lead in the RV, which is not pacing. And whenever there is a arrhythmia, that defibrillator lead will take care of it. It will give the shock. While patients in home, we are giving CRTP only, the pacing only. That's cost around 5.5 to 6 lakhs. There is no defibrillator function in that, and there the left bundle pacing alone will be helpful in 2.5 to 3 lakhs only.
Incidence of arrhythmia will be less in LVB pacing.
That will be there, because that will be there in the CRTP as well. There is in CRTP also there is no defibrillator lead.
Dr. Tripathi, it is useful in all the cardiomyopathy with low ejection fraction, but can we use in the if QRS duration is also not by normal and with low ejection fraction, but no AF and no any evidence of or a running episode of the ventricular tachycardia, then still it is indicated or helpful to the patient.
Sir, if QRS is normal, that is LVBB is not there, then we are not going to correct anything. We will pace left bundle only with hope that in future patient will not have LV dysfunction because of the right ventricular pacing or LVBB morphology. There, we have to give the defibrillator function as well in those cases.
Okay, thank you, boss.
I request Dr. Tripathi to felicitate Dr. Jha. He's left only one.
Okay, now there is a lucky draw. Please come, lucky draw. Yeah. Hi, please come. Dr. Tripathi, please. Lucky draw nikal dijiye, being the last speaker. Unbeaten batsman. Unbeaten batsman.
नहीं है उसका हटा देंगे मेरा
अरे मेरे को बुला ले ऊपर यार।
सर दिखाओ फोटो फोटो खींच रहे हैं
चाहता सर मेरे बंदा
डॉक्टर एसके शर्मा। नहीं है, नहीं है, दे दो यार, बहुत कम लोग, नहीं मिलेगा कोई।
डॉक्टर पवन पांडे,
तुम करते रह जाओगे,
कोई बात नहीं। डॉक्टर पवन पांडे,
चलो एक एक करके निकालते चलो। डॉक्टर विपुल शर्मा, कोई नहीं मिलेगा यार, निकालते रहो। डॉक्टर प्रवीण भाटिया, चलेगा।
सारे निकालो थोड़े।
डॉक्टर जयेश गोयल, अरे क्या फायदा यार, अब ऑर्गेनाइजिंग पर्सन को दे दो सबको।
डॉक्टर राजीव गुप्ता,
डॉक्टर अनिल गोम्बट चले गए।
राजीव गुप्ता, डॉक्टर राजीव गुप्ता,
डॉक्टर राजीवा गुप्ता, राजीवा है नहीं है। मैंने दिया ही नहीं, मैंने
आपका
बॉस को निकाल लो, बॉस
डाला होगा और निकाल लो,
बहुत निकाला अपने डिपार्टमेंट के निकलेंगे
और निकालो, और निकालो सर।
अमर करना नहीं, चला गया। वैसे अच्छे लगते हैं, खड़े हो गए। हाँ ये
छाड़ा चलेगा।
किसका तो आ जाएगा। आलोक जोशी,
ये भी चले गए।
सारे खोल लो थोड़े ना, सब खोल लो, पता लग जाएगा। किरण छाबड़ा,
किरण छाबड़ा के सर को दिया जाए।
राजीव गुप्ता ये भी नहीं है।
डॉक्टर राजीव गुप्ता है,
ये झा सर,
एसके अरोड़ा, अब कोई नहीं बोलेगा मेरा भी होगा।
अच्छा ठीक है।
चलो बस हो गया,
ये हो गया जी, हो गया, चलो
हो गया सर,
चलो।
भाई मुझे लेने तो दो। ये देख, ये देख, भाई इधर भी ले ले।
मैं तहे दिल से सबसे पहले डॉक्टर किरण छाबड़ा का धन्यवाद करूंगा, मेरे को टाइम दिया, और वाइफ ऑफ ऑल द ऑर्गेनाइज कमेटी जो हमारे एनडीपीएफ मेंबर हैं, उनकी वाइफ को थैंक यू करना चाहूंगा कि उन्होंने इन बच्चों को, जितने भी मेंबर को टाइम दिया हमारे काम करने के लिए। थैंक यू वेरी मच। होटल स्टाफ को, ऑडियो विजुअल वालों को, जो रिश्ते में बैठे थे, सबको तहे दिल से धन्यवाद, वेरी गुड धन्यवाद। एंड मिस्टर प्रदीप मिश्रा एंड रवि एंड मुकेश, ये होटल मैनेजमेंट में उनको थैंक यू करना चाहेंगे, और जितने भी स्टाफ जिसका मैं नाम नहीं ले सका उनको भी धन्यवाद। थैंक यू वेरी मच, थैंक यू। आज मेरी मौज बन गई और मैडम को देंगे खुश हो जाएगी।